Hey everyone, welcome to Vitals Up. Today we're diving into sepsis, a life-threatening condition that many people misunderstand. Let's break it down step by step. What even is sepsis, you might ask? Sepsis is a systemic inflammatory response to microbial invasion. Basically, it's your body going into overdrive to fight an infection. But how do you know that the patient is having a systemic inflammatory response? That's where the SIRS criteria comes in. You need at least two of the following: a temperature of above 38 degrees Celsius or below 36, a heart rate of above 90, a respiratory rate of above 20, a WBC count of more than 12,000, less than 4,000, or even more than 10% bands. Remember that bands are immature neutrophils and more than 3% of bands is what you call a left shift. Now, there's a catch with this criteria. For example, after exercising, someone might have a heart rate of above 90 and a respiratory rate of above 20. Does that mean they're having sepsis? Of course not. So while the SIRS criteria can help, it's not used as the sole definition anymore. Today, sepsis is defined differently. According to Sepsis 3, it's an infection causing life-threatening organ dysfunction. And don't worry, later in this video we'll go over the specific criteria doctors use to identify organ dysfunction so you'll know exactly how it's recognized. A lot of people think that sepsis always means bacteria in the blood, but that's not true. In severe sepsis, blood cultures are positive in only about 20 to 40% of the cases, and in septic shock, it's about 40 to 70%. So, sepsis can happen without bacteria in the bloodstream, and that's actually way more common than people think. So, what actually causes sepsis? Most are triggered by bacterial infections. Around 60% are caused by gram-negative bacteria, and about 40% are caused by gram-positive bacteria. However, fungal infections can also be a cause, but are very rare and usually happen in people with weakened immune systems. Sepsis can come from different sources depending on the patient. For otherwise healthy people, the most common cause are infections in the abdomen, the urinary tract, or the lungs. For people who use intravenous drugs, bacteria like Staphylococcus aureus or Pseudomonas are more likely to cause sepsis. Here's how bacteria cause sepsis in a nutshell. Endotoxins such as lipopolysaccharides from gram-negative bacteria trigger immune cells to release inflammatory molecules. Exotoxins like peptidoglycans from gram-positive bacteria can act as superantigens, causing widespread immune activation. Together, these molecules create a systemic inflammatory response which can lead to organ dysfunction if not treated promptly. For infections caused by gram-negative bacteria, risk factors include diabetes, liver cirrhosis, lymphoproliferative disorders, invasive procedures, and burns. For gram-positive bacteria, the main risks are IV drug use, burns, and vascular catheters. Finally, fungal infections usually happen in immunosuppressed patients or after broad-spectrum antibiotic treatment. Knowing these risk factors can help doctors identify patients who need careful monitoring. Patients with sepsis often present with the classic triad: fever, rigors, and low blood pressure. Other signs that can suggest sepsis include low urine output, a fast heart rate, fast breathing, altered mental status, and skin changes. It's important to remember that in elderly patients, those who are malnourished, immunocompromised, or have chronic illnesses like diabetes or cirrhosis, the usual symptoms may be subtle or even absent, so clinicians need to stay alert. Sepsis can lead to several serious complications. Acute respiratory distress syndrome is a condition that affects about 20 to 50% of sepsis patients and is often due to a gram-negative bacteria. It's diagnosed when the oxygen levels fall below 50 millimeters of mercury and the chest X-ray reveals widespread lung infiltrates. Septic shock, characterized by persistent low blood pressure despite adequate fluid resuscitation. Patients also have bounding pulses. Septic shock is a warm shock, which basically means that the patient's extremities are going to be warm, and this can be differentiated from a cardiogenic shock, which is cool. Kidney complications include reduced urine output, azotemia, and proteinuria, and these are often caused by acute tubular injury from poor perfusion. The patient can also have low platelets and disseminated intravascular coagulation. GIT problems include cholestatic jaundice, which may even appear before other signs of sepsis. LFTs are abnormal and usually normalize after recovery. There are also blood glucose changes. Diabetic patients often develop hyperglycemia, while those with liver disease may experience hypoglycemia. To identify organ dysfunction and sepsis, doctors often use the Sequential Organ Failure Assessment Score or the SOFA score, but it takes time and isn't practical in emergencies. Instead, we rely on the Q-SOFA or the Quick SOFA. If the patient has two or more of the following, then they're at a high risk for poor outcomes. The mnemonic is HOT. H for hypotension, systolic blood pressure less than 100, O for orientation, altered mental status or Glasgow Coma Scale less than 15, T for tachypnea, respiratory rate more than 22. On top of that, a lactate level of above 2 millimole per liter is a strong warning sign of tissue hypoperfusion and poor outcomes. Once sepsis is suspected, action must be fast, ideally within the first hour. That's why we follow the Sepsis 6 bundle. First things first, you need to get a senior or ICU help immediately if the patient is unstable. Give high flow oxygen to keep the saturation between 94 to 98% or 88 to 92% in patients with COPD. Establish IV access and take blood samples for full blood count, urea and electrolytes, CRP, and lactate. Collect blood culture before giving antibiotics only if it won't cause a delay. Start broad-spectrum antibiotics promptly and consider source control. For example, remove infected lines, drain abscesses, or arrange surgery if needed. Give an IV crystalloid bolus until lactate is under 4 millimole per liter, systolic blood pressure is above 90, or mean arterial pressure is above 65. And then finally, keep track of urine output and repeat lactate measurements if needed. If lactate is still above 2 millimole per liter, repeat after 2 hours. Following these steps quickly can dramatically improve outcomes for patients with sepsis. Early sepsis management starts with IV antibiotics and rapid fluid resuscitation. Piperacillin tazobactam 4.5 gram is commonly used every 6 to 8 hours, with gentamicin or vancomycin added if resistant bacteria are suspected. Fluids are given as 30 milliliters per kilogram of crystalloid over 10 to 30 minutes. If the patient remains hypotensive despite fluids, they will usually be escalated to ICU, where norepinephrine may be started as a continuous IV infusion, typically at 20 nanograms per kilogram per minute to support blood pressure. And that's all on sepsis.